Hello. This is an opportunity to get to know the incoming president of the British Science Association. He's taking up his role at a time of, I think it's fair to say, unprecedented turmoil around the role of science in our public health and our national security. Professor the Lord Darzi of Denham has a long and distinguished career already in public health, with a long-standing commitment to encouraging innovation in technical surgery and enhancing patient safety and care. He holds the Paul Hamlyn Chair of Surgery at Imperial College London, the Royal Marsden Hospital and the Institute of Cancer Research, and he's Director of Imperial's Institute of Global Health Innovation. Lord Darzi also has direct experience of politics and policy making because he was Health Minister in Prime Minister Gordon Brown's government from 2007 to 9. He's been knighted for his services to medicine and surgery before being appointed to the House of Lords, and has been the UK's Global Ambassador for Health and Life Science. Lord Darzi, welcome. And I wanted to ask first why you decided to take up this role as President of the British Science Association.
Thank you, Samira. Well, it's a great privilege to be asked to be the president of this august organisation. And if you look at its history, it's made significant contributions over 200 years. And I think it provides me as well with the platform to really explain what science is, engage the public with science, and also stimulate many creative minds as we go through school during COVID, that science has a very important role to play in our everyday life.
Right. I want to talk a little bit about your career journey. I mean, I've made it clear in introducing you. You have a long and distinguished career in surgery, in medical care in the UK, in the NHS. What, in brief, has motivated you? And can you give us a sort of summary of the kind of career path you've taken to where you are now?
Well, I decided to do medicine, and I think that goes back to when I was 5. You probably know that I was born in Baghdad. At the age of 5, I had meningococcal meningitis. And in the West, the mortality rates from that, in that time, in the early 60s, would have been somewhere around 25–30%. And in that part of the world, probably higher. So surviving meningitis after being in hospital at the age of 5 for more than 1 month, getting intravenous injections every day, I think that's where the passion came in towards medicine. Although early days, I came from an engineering family, so being with Dad was all about engineering, and I think he was a bit disappointed when I had the rebellion of not to do engineering and decided to do medicine.
Not the kind of rebellion most of us normally would expect.
Yeah, we accepted it eventually, but so then I went to Ireland to study medicine, and this is the 1970s, and you wouldn't describe Ireland as the most diverse country. And I had a fantastic time studying medicine in Ireland. And then I decided to do surgery at the end of that because it was nearer to engineering, it was more mechanical, it was more kit. And I did my initial training there, and I came across to the UK to work in the NHS because, if you're in Ireland, look at the NHS, the size of it, it's big and it's well known, it's admired worldwide. So I worked there as a senior trainee, and I was given a job working as an NHS consultant, which was fantastic. At a very young age, I was 32, 33 when I got the job. And then it's quite clear to me all throughout my life that, if you're a doctor or a surgeon, what really gets me to work is to provide the best quality care you can. And the only way to do that is through innovation and research. So then I had the opportunity of joining Imperial, which meant changing from working in the NHS to the university, but I was absolutely guaranteed that I will continue my love in life, which is to look after patients. And so I became a clinical academic, and I've never looked back. And I've been very, very happy combining the two, bringing discovery from the bench to the bedside, and also bringing many of the problems from the bedside back to the scientist.
And to kind of zoom ahead to, the last few months, you worked in intensive care during the early peak of the COVID-19 pandemic in your NHS hospital. Can you tell me what you did and why?
Well, if you remember February time as the pandemic was growing globally, there were a lot of surgical activities were coming to a standstill because we were unsure there were COVID admissions in the hospital. Well, something else happened is my daughter became ill with some fever and cough, and that was early days where we can get tests done. So we decided, because I had an exposure, that I would get tested too, and the whole family did. And she tested positive, my son tested positive, and he had no symptoms at all. So we ended up quarantining in the first 2 weeks, the last 2 weeks of February. And that was, that was my exposure to quarantine. This is before the lockdown. Mm. When I went back to hospital after the quarantine, there was a complete change in the hospital. There was fear in the faces of many. I think part of it was access to test, part of it was they didn't know whether they had COVID or they had a cold. And there was the fear element. It was building up. And the intensive care unit beds were getting fuller, there was shortage of staff, and I decided to volunteer. I mean, I haven't, some of my patients would be in intensive care, but I've never really worked in intensive care. So I decided to volunteer. I did a quick course in ventilation, and I went to the intensive care unit. And the striking thing there was, unlike every other day I'll go there, was every patient was COVID, COVID, COVID. And what was the other thing which I picked up, the heroes there were the nurses, because actually most patients were on a ventilator stable, but they had to be turned around, something we call proning, which I've never seen before. When you have a patient on their tummy, you can actually improve their oxygenation. Again, science, none of us did that before. So I was helping the nurses to turn the patients in their beds. That's really what I did. A couple of occasions I walked in with the personal protective, the PPE as we call it. They don't know who you are, so you put your name down as Ara, and no one recognized with that. So I said, what could I do? And I remember one nurse in one ward said, well, the bins haven't been cleaned, could you change the paper? So that's exactly what I did. So, in these situations, everyone puts their hand in. And might I just say, there were a number of other volunteers after, and the question is, how do you neutralize that fear? And, the NHS workforce have done a remarkable job during this.
What do you think you learned from that experience?
Well, firstly, the shock of the number of patients with a single condition being in the intensive care unit, being unwell, that was the shocking bit of it, but also the admiration to many of my colleagues who really were working day in and day out, engaging the relatives and of the patients we had, because we couldn't communicate. The relatives weren't allowed to come in. So, at the end of the day, there were phone calls to relatives explaining what's happening. It was a very stressful environment. But everyone knew that the whole nation was behind them and supporting them.
One of the big issues that people are talking about now is how much data there is showing poorer people have poorer health outcomes. We know this was true before COVID, but we really see it now. And to some extent, there's a whole overlap with ethnicity as well. What do you think the government should be doing about that data?
Well, that became apparent, as you said early on. I mean, we've known from the past that lower income associated with significant health inequalities. And I remember even 10 years ago when I did the London Commission, where we had that famous, when actually in fact the Prime Minister was the mayor, where we had this famous tube line, the Jubilee line, showing the life expectancy in Westminster versus Canning Town dropped by about 10 years. So these did exist. What COVID did significantly exacerbated that. And that's a serious issue which we need to tackle. We've always been talking about it, but I think we need to address that in a number. With data, you can actually stratify. You can identify where the risk populations are. They need better protection. They need better engagement. They need better education. And these issues need to be addressed at a local level. You can't do these things at a national level. You need to do it at a local authority level in addressing the major risk, the risk profile of the population that could be impacted with COVID, beside what we know about obesity, obviously being another risk, age being another risk, but obviously black and ethnic minorities also is a significant risk. And by the way, we saw that every day in our own NHS, because a significant number of the mortality of physicians, doctors, were of black and ethnic minorities.
Well, I wanted to ask about that because and broaden it out perhaps. I mean, the Black Lives Matter spotlight, Summit at the Me Too spotlight, had refocused attention on enduring discrimination more broadly in science. What's your view on how far that's genuinely changing, especially given, as you say, with COVID, we saw big difference in how it seemed to impact people in the healthcare system who were of minority backgrounds?
Well, it is changing, not necessarily at the speed we all want it to change. Certainly there is, I see this as one of the areas that I will hope to be contributing as the president of the British Science Association. I think if you're looking at excellence in science, you need diversity, you need more women, you need more people with a background of black and ethnic minority. We need to open up these opportunities. We need to encourage. You need to start at school age. You can't do it later on. You really need to engrave that every person has the potential of making a contribution in science. And that's why I think COVID, if there's one positive thing in COVID, is most of the population out there realize that science is the only way out of this. So I will be strongly encouraging within my tenure and how could we engage that community better to achieve a better outcome at a faster rate than it was.
One of the things I want to take a moment to talk about is the fact that you have been a government minister, which is relatively rare now, I think, for scientists who are practicing scientists to also have government experience. And you have always encouraged scientists to get involved in policy. Can you tell me a bit about what you mean when you say get involved in policy and why you think it's so important?
Sure. I was appointed at a time where politics, I remember they were called the Government of All Talents, which stood for GOATs. So I was the health goat. When it comes to science and policy, I mean, science is about discovery. That's one element of it. But you could discover many things in life. If you don't diffuse that discovery and translate that into a health benefit, what's the point in doing it? And policy is one part of that pathway. So first you do the science and discovery. Second, you do the trials and show the effectiveness of whatever you're working on, whether it's a robot, whether it's a new drug. And then you need policy. You need to impact policy. And I'll give you the best example of that. Again, 2006. We knew that innovation in stroke has transformed stroke care. But in London, there were 32 hospitals doing stroke care, well below the standards. So a big engagement with the public, by the way, firstly, with the patients, with the physicians, with the scientists. We decided that London needs 6 comprehensive stroke centres. That led to saving 200 lives a year. It reduced the morbidity of stroke, so more people walked out without the stick. And that is a significant change. It became a Harvard Business School case study. So that wasn't just about the discovery, it's the change you have to do to implement and create value of that discovery is critical. And you know, science and discovery is a moving target, and you have to keep up with it. What you did or what you planned a year ago, it could be out of date today, and we need to think through. And that's why science and clinical practice go hand in hand, and that's why scientists need to be much more involved in policy making, or evidence-based policy making is what I believe in.
You were also in government at the time of the swine flu outbreak in 2009, H1N1, and at that time you said that the government had been planning for a flu pandemic for 5 years. Looking back, what lessons do you think you learnt from that whole time?
Well, there's a bit of a déjà vu, actually. The early days when COVID was embracing us all. I mean, what happened then was sometime in July 2009, the infections started. Yes, we were prepared, but you're never prepared well enough to tackle the issue. I mean, thank goodness in those days it was an H1N1, so it was a flu type of illness, where this one is very different. This is a coronavirus. We've never had coronavirus reach our shores before. You know, SARS never came near us. Well, we knew about it. MERS is another coronavirus. But H1N1, you know, diagnostic tests were available. There were 4 labs that were used at the time. But there were serious debates about how do you treat that. Thank goodness in those days there was Tamiflu and Relenza. And they were available, but there was a big uproar which I had to defend in Parliament. Have we ordered enough? We essentially ended up ordering 200 million of Tamiflu, which was very, very, by the way, very excellent in terms of the response from the patient's perspective. There were predictions then, more than 60,000 people will die from H1N1. Ended up a couple of hundred, I think, if I'm correct.
So there was a criticism that you'd ordered too much Tamiflu, given the
You can't win in these
yeah.
things. And I'm sure, but that's, hindsight is 2020, but, we've been going now through making decisions which, 5 years from now we may look back on them and decide what worked and what didn't work. But, that is what, it's a pandemic. It's a pandemic emergency.
The future of the NHS is very much a current debate because of decisions being made during the pandemic. And one of the big issues that's emerged is people questioning this mantra, protect the NHS, given there was the long-term impact, which we're only really starting to see now, of the cancellations of treatments of so many thousands of people with cancer, with other serious conditions. Did it concern you, the way everything was being framed around protecting the NHS?
Well, a mantra is a mantra. I think if you remember those days in January or February, if you remember the pictures coming from Italy, where they had patients with COVID in the corridors being ventilated, these were alarming pictures. And it wasn't about protecting the NHS, it was about protecting capacity to treat COVID patients in the most dignified and respectful way as possible. So it was about creating capacity in the intensive care units and the wards to receive COVID patients rather than see some of the pictures we saw on television in Italy. So I don't think that was wrong. Maybe the wording could have been different, but it was about creating capacity. That's one. Also, it was about protecting patients with cancer who might have been on chemotherapy to come to a hospital where they may actually get COVID. These were early days, and we've learned a lot from it, because since then, we have now separated what is a COVID environment, what is as much as possible a non-COVID environment. By the way, you can never have a COVID-free environment in a hospital.
No, but the Nightingale hospitals weren't used, and the deaths that are happening because people's treatment was cancelled, is a massive issue.
I think within the first 4 weeks, as you may know, a campaign started encouraging those who may have chest pain to attend A&E, but I think rebuilding the patient confidence in bringing them back to hospital where they knew that most of the hospitals have COVID was an issue. Yes, absolutely, and I agree with that. And the question is, how do you get that balance right? Nightingale's hospitals, by the way, it was an insurance policy that we don't end up like what happened in Italy and Spain. Yes, there was a small use of them, but if we didn't have them, and we ended up in treating patients in corridors in the most undignified way, and there were a lot of criticism in those days. Do we have enough intensive care beds? And famously, many opinion leaders said we are short, significantly shorter than intensive care than any other European country. So it's all context. Yeah. Hindsight is beautiful to look at.
If you take a step sort of outwards from the specifics of COVID, it's a time when the relationship between government and, another phrase, following the science, is very much debated. How do you see the current situation? Everyone's talking about the science, but I wonder if there's more confusion rather than less confusion about what following it means.
I think you're right. There has been tensions there, and I think it's time for a reset. I think science needs to be clearer, more coherent, less speculative, and in some instances confidential. If you're an advisor, you advise confidentially. I think from political perspective, I think politics needs to be much more transparent in how they translate that science into policy, because the only way out of this is science, as I said earlier. I think both we have a very important role to play in carrying the public with us in terms of understanding the science, and also remembering on both sides that science is a moving target. What we knew about COVID in February and March, when the outbreak started in this country, is very different than what we know about COVID today. And again, we have to embrace this country it was actually in the New York Times last week. This country contribution to new therapeutics through clinical trials beats anywhere else in the world. So there's a lot to be proud of as well.
You mentioned the need for politicians to be more transparent when they are citing science as a justification for policy. How would that work in practice? Can you give an example?
That's more about explaining. I mean, ultimately, could I just say there's a very clear motto. Science advises, politicians decide. There's no question about that. That's an elected government representing the public. They are the accountable. So science advises, politicians decide. It will be good if politics explains how these decisions were made. There will be a lot of trade-offs when decisions are made, and the most famous trade-offs, as we know, the lockdown would have been a good example of that. Although that's the only way to protect, we can't have a lockdown until this pandemic is over, because our economy will be in shatters. So these trade-offs could be explained more transparently, and I think science is there to advise, but not to make decisions.
So you did talk as well about advisors being there to advise, and I think you also said that advice needed to be confidential. Maybe it wasn't the word you used, but you implied there's an issue about what chief scientific advisors should be saying in public, and maybe what they shouldn't.
Well, I must say, the chief scientific advisors are there. I mean, there is a single narrative that combines the two. If you remember, our chief scientific advisor, CMO, are essentially hand in hand with politics, have the same narrative. I've never seen any problems with that. But if you are an advisor for government in any role, and I have been previously, that's a privilege. You either take it or leave it. And if I'm becoming your advisor, I'll give you confidential advice about something.
Confidential.
And that is what's important about it. But confidential is one thing, but you need to be as open and transparent with that advice as possible.
What about ex-government scientific advisors? You'll know Sir David King set up an independent SAGE.
Well, I have huge admiration to Sir David King. I mean, in his time, in his tenure as the chief scientific advisor. But I was really baffled with this independent SAGE. Well, firstly, who's he advising? You know, that's the type of thing that erodes confidence in science. And so I was surprised why there was this independent, what's this purpose, and who is it advising?
A key belief of yours is about the importance of innovation, and it's something that's marked your career, about being willing to experiment and use new technical innovations. Can you talk a little bit about what it means in practice to be pro-innovation and how it's shaped your work?
Well, your basic principle, if you are working in the health service or any form of healthcare, what matters to all of us as a doctor, nurse, but more importantly to the patient is quality, is the quality of care. Now, the quality of care you provide is underpinned with the science, and quality is a moving target. We constantly need to chase that, and innovation is what leads to that. So pre-2006, we were treating stroke very differently than we were after 2006. Innovations we've seen in cancer treatment. The way I did my cancer training and what I did surgically or treating a patient after surgery is complete history. We treat cancer completely differently. So innovation is, we need to embrace innovation, and we need to accelerate a discovery or an innovation in really scaling it out population at a much quicker and a much speedier rate. So I have the privilege of chairing something called the Accelerated Access Collaborative, which brings industry together with science, government policymakers. How do we get some of these innovations into the health service quicker, at a greater speed, and obviously across the whole country, which is absolutely critical. There is no standing still, because if you stand still, you will fall back.
Are there changing trends or ways in which science you see working?
Yes, science is changing. I think the boundaries between what we've historically known scientific disciplines like chemistry, physics, biology, all these boundaries are getting more blurred. And we're really talking about convergent science, where these knowledge bases come together. So it's a team effort. So if you cross the way to Imperial, where we are, the British Science Association, you will see that most labs will have groups of different disciplines working together towards a single disease entity or a new discovery. And that's what we call convergent science. And I think that's very important, and we're embracing it at Imperial and many other universities in this country. And we could do that very well here.
The relationship with industry is always a question, and to some extent it's an ethical question. It's one that the public worry about, where they sometimes feel there's a market imperative and it might not be prioritising public safety. What's your view on the role of industry, and indeed how far perhaps it's changed over the last few years?
Well, science fuels industry. When you have a discovery, it isn't just the health value, it's the economic value of that. And let's not underestimate that. As I said, life sciences brings to this country anywhere between 3.4 to 3.6 of our GDP. Industry does a lot of science, and many discoveries have come from the industry side. So I think they go hand in hand, and we are in many ways endowed in this country of having some of the biggest pharmaceutical companies who've made a significant contribution in this country in not just improving outcomes, but improving the quality of life that comes with that. And we're in the midst of COVID, we're all waiting for the vaccines, we are waiting for the new therapeutics. So, they have an amazingly important role to play.
You were mentioning vaccine, and one of the big concerns that has emerged through the COVID pandemic is the sense of a nationalised competition instead of a WHO-led international cooperative approach. Is that going to be a challenge, do you think, in the next year or so in science? Nations competing with each other on the stuff that we're used to collaborate on?
Yeah, well, I think firstly, we should separate the political rhetoric, which we've seen across the Atlantic and elsewhere, about nationalistic and this is for us and all of that. Separate that. When it comes to the science and those really involved in the science of the vaccines, the manufacturing of the vaccines, industry, for example, as well, there's a huge amount of global collaboration going on, absolutely, between different countries, different scientists, and that's a good thing. We've always done that, and we'll continue to do that.
You don't think it's under threat?
I don't think it's under threat. WHO is there, and I think the launch of Gavi and CEPI and raising money to support vaccine, provide equity in access to vaccine to lower and middle income country. By the way, Britain led on that initiative. In London, raised more than £7 billion for the vaccination program globally. That is an amazing political leadership in bringing countries together to put investments into the pot to really support lower and middle income countries. We should be very proud of that. We should ignore the rhetoric.
I'm not sure if we can ignore the politics on the next issue I'm going to ask you about, which is Brexit, and how far the ongoing uncertainty about that, and indeed its impact, is changing how British scientists need to operate. What do you think will change?
Well, I think it could have an impact, you're absolutely right, but I think what's important to do is how do you mitigate any negative impact. What is unique about science in this country is that we attract the best scientists from the world. It's not just Europe, across the whole globe. And we need to maintain that. We need to build the reassurances that you're welcome to come and work in universities in this country. You are welcome to come and work in industry in this country, in life sciences industry in this country, because it's absolutely critical. And underpinning that with the funding envelope that's required. And to be fair, the government in the last budget announced a significant rise in the research funding. To cover the gap as we leave Europe, we're going to lose access to European funding, which we used to get before. So as long as we're welcoming to scientists to come here with special visas, welcoming to their families, coming here and working, I don't think we will lose the ground, but we need proactively to do that, because it's not just saying you have a visa. There's a lot of reassurances that needs to be given out there that we're welcoming.
Especially if, as we know, there's already evidence of scientists leaving because international projects are withdrawing from the UK part and setting up elsewhere. So that must be a concern.
That is a concern. That's why we need proactively addressing this. And I'm sure it's in the priority of government officials, ministers, because science underpins a lot what we do. We are well known globally in the quality and the integrity of science in this country, and we need to maintain that at all costs.
Do you have a priority that you would like to see the government push in terms of this extra spending on research and development?
Yes, I have, and I've dealt with that confidentially, and I think in the last budget we've seen some funding. And may I just say, it's not me, there are many, many senior scientific colleagues across the country who who've been pushing for this, from vice chancellors to academics working on benches, and absolutely critical that we maintain our excellence in science in the United Kingdom as a whole.
I want to ask a bit more about privacy, because I think there is growing public concern about the loss of privacy linked to technological innovations in science and policy. A very obvious current example is track and trace, which is making people nervous if and when the system is properly working. Are you concerned either about the privacy issue itself or about the fact that public attitudes are, I think one could say there's a fair amount of concern and scepticism?
Yeah. Well, I think I'll start by the premises. If we want to get on top of this virus, we need to chase the virus. If we're chasing the virus, we need a tracing system. I think we have enough science and technology to ensure that all of that data is protected until such time if there is an infection, so we can actually, screen the people in which you've had a contact with. I think all of that is manageable, and eventually the NHS digital tracing app will be available, and that will retain all the confidentiality and privacy, by the way, which is a law in this country. No one is breaking any laws. I think if you compare that with the amount of data that we share on a daily basis, take Facebook, for example, this is a drop in the ocean if you compare with the amount of data that Facebook will have on us. So let's put this thing in context. What we're trying to do is to fight a pandemic.
I want to ask about the balance between the public or the patient, if we talk about the medical side of it, their role, and the balance of power with scientific institutions and bodies. And I'm just thinking, as a news journalist, in the last year, we've seen such appalling health scandals around vaginal mesh surgery, the rogue surgeon allowed for years to carry out unnecessary breast surgery, maternity care deaths. Interesting coincidence, these are all factors that particularly affect women. One wonders actually how much has really improved about putting the public in the right role in terms of a lot of big scientific decisions.
Sure. I think there are two components with this. Firstly, the examples that you gave. I mean, there's plenty of data out there, and I think these are failures of audit and failures of governance. We could have picked up these issues much earlier in terms of collecting this data and making that available transparently.
Listening to whistleblowers, maybe.
And listening to whistleblowers, absolutely. So that's one important issue we need to look at. But on the other hand, when you come to science, may I just say we are the most progressive countries in the world. Every time I will apply for a Cancer Research UK funding, for example, I go to an interview panel, once shortlisted, there will be at least one or two patients and a member of public on that panel. Every grant I apply for the Engineering and Physical Research Council or the Wellcome Trust, there is a section in it explaining in layman's language, what does the science do to me? So we are well ahead in terms of engaging the public and the patients. But you never reach a peak there. The more you do, the better it is. Because ultimately, you're using taxpayers' money to do this research on one hand. On the other hand, you're talking to the patients who benefit. So patients and public engagement is part of everything we do. And the champion of that has been the National Institute of Health Research, the NIHR. So we are well ahead. So I'm very happy with that. We can always do more. The first bit is about clinical audit and not picking up, and failure of clinical governance. That a surgeon is doing breast cancer surgery unnecessarily. That wasn't picked up, that wasn't challenged. And I think there's still more to be done there.
You wrote in April about the need, when it came to patients, for health security rather than health care. What did you mean by that distinction?
Well, this is a piece of work that I've been working with an amazing scientist who actually an MIT graduate on across the pond in Boston, Nubar Afayan, which is, we need to look at health or health security the same way as we protect ourselves physically. We all go out, walk in the street. We know there is a system that protects us. We need to be thinking about health exactly within the same premise. We need to be ready when a pandemic hits you. We need to have the science bases. We need to be the manufacturing bases to tackle many of these threats. So we need a pathogen shield the same way as we have a shield, for example, from nuclear weapons. We have more nuclear weapons at the moment to actually wipe out humanity twice over. why don't we spend a small amount of money to really introduce this concept of securing our population from external threats like this pathogen which hit our shores? Because if you look at the economic impact of this, then you realize potentially if we spend a little bit more to protect ourselves from these things, potentially we could have saved significantly more from the cost of COVID.
Science is often about pushing into unknown frontiers. What's the biggest risk you've ever taken, and what's your view on risk in science?
Well, I think I take risks every day because I'm a surgeon. Surgery is a risky business, but I'll do my best, and experience brings a lot into this in mitigating that risk. And obviously, there is another human being on the other side of this risk, who's the patient. So you need to be absolutely sure, engaging the patient, because any surgical procedure, however small, however big, has a risk carried with it. So my duty as a clinician, entrusted in looking after that patient, is mitigating that risk as much as possible.
Well, in terms of scientists more broadly, sometimes there's a concern that can science sometimes be lackadaisical about risk, particularly when it affects members of the public. Do you have a view on the role of risk more generally?
I think science and risk, I think the biggest risk I see in science is to be speculative. You know, science is about evidence. Science is about weighting and generating that evidence. Once you start into speculation, that is a big risk, because you lose the public confidence when you start speculating. And I think we've seen some speculation in science across the globe, actually. I'm not talking about here. And that's not, I think that's dangerous.
Is there a biggest lesson or lessons that you've learned in your career?
Yes, I learned the biggest lesson in my life, which took a while to learn, is if you want to achieve something in life, you surround yourself with people who are smarter than you. The team you work with, the team that you engage with, is absolutely critical to achieve that ultimate goal. Science is a teamwork. Clinical surgery is a teamwork, and that's absolutely critical.
And finally, what do you think are the key challenges facing British science right now?
There's always the challenge of funding when you come to science, obviously. The second is, we talked about this earlier, we need to be the country that attracts the best scientists in the globe. We need to look constantly at the regulatory framework to allow us enhance our ability to translate science into practice, and we need to make sure that we continue to have a pipeline of the best brains, which this country has, ends up in science, not necessarily in universities, by the way. They could end up in industry, they could end up in other roles, because our economy is dependent on our scientific base.
Lord Darzi, thank you so much.
Thank you.